Students, and welcome to part 2 of the digestive system. Here we're going to look at the pharynx, larynx, and I think the stomach is in this one as well. So let's start off with our pharynx. Here's a couple pictures I have on the right hand side, and you'll notice where the pharynx is located. Now, we already know it's a muscular funnel, and it's going to connect this oral cavity. This oral cavity to the esophagus, which you see down here, as well as connecting the nasal cavity to the larynx. Now it has a deep layer of longitudinally oriented skeletal muscle and a superficial layer of circular skeletal muscles. Now we know that the circular muscle is divided into a superior, an inferior, and a middle pharyngeal constrictors that are going to force food downward while someone is swallowing. And when food is not swallowing, we have this inferior constrictor that remains contracted to exclude air from the esophagus. Now this constriction is considered the upper esophageal sphincter, which you see right here. Okay, and it allows it not, although it is not an anatomical feature of the esophagus. Now the upper esophageal sphincter, it disappears at the time of death when the muscles begin to relax. Thus, it is considered a physiological sphincter rather than anatomical. Now, the esophagus, as you see right here on the right-hand side, is very long and it's straight. It's approximately 25 to 30 centimeters long. Now, it begins at the level between our vertebrae C6, or cervical 6, and the cricoid cartilage. Now, after passing down through the mediastinum, this esophagus, it penetrates the diaphragm. So here we have the diaphragm here. Okay, and it's going to penetrate this diaphragm at the esophageal hiatus, and then it's going to continue another 3 to 4 centimeters between the stomach, to meet the stomach, right in here, at the level of our thoracic 7. Now the opening to the stomach is called the cardiac orifice, and that's because of its position in the body, relatively near to the heart. Now food is going to pass briefly at this point because of the lower esophageal sphincter, or LES. Now this LES, the lower esophageal sphincter, it prevents the stomach contents from regurgitating into the esophagus. And of course, heartburn has nothing to do with the heart, but it is the burning sensation caused by acid reflux. So when the bolus, because at this point the bolus, when it leaves the mouth and it has accumulated all of the moisture and the food has been broken down by the enzymes in the oral cavity, it passes down through the pharynx, then it gets into the esophagus. Of course, it passes these particular sphincters that are going to control the amount of food that is passing into the esophagus as well as going into the stomach as well. Now, the walls of the esophagus, it originates into the typically digestive system layers with some regional specialization. It has the mucosa that has a non-keratinized stratified mucous epithelium, and the submucosa. and that contains the glands of the esophageal, and those are the ones that are going to secrete any type of lubricated mucus into the lumen. So of course we're going to have the bolus continually being supplied with mucus on the way down to the stomach. Now when the esophagus is empty, now the mucosa and the submucosa are deeply folded into the longitudinal ridges. Now most of the esophagus is in the mediastinum, where it is covered with connective tissue called adventia, which merges with that of the trachea as well as the thoracic aorta. Now let's look at swallowing. Now swallowing, it involves over 22 muscles in the mouth, the pharynx, and the esophagus, and is coordinated by the swallowing center in the medulla oblongata. Now the swallowing center, which is a pair of nuclei, is going to communicate with these muscles of the pharynx and the esophagus through the trigeminal, facial, and two other nerves. Oh, the glossopharyngeal nerve and the hypoglossal nerves. So they're going to communicate with 4 facial nerves. 4 facial nerves to help with communicating. Well, sorry, to help with getting the muscles to react and getting the food swallowed. Okay, so swallowing occurs in 2 phases. So on this slide here, I do have the various phases. Slide here, 27 and on 6. But I want to actually show you guys the picture here while we go through these phases. Alright, so the very first phase, or the buccal phase, is under voluntary control. We have the tongue that's going to connect with the food, then it's going to press it against the palate, of course. Right, it's going to press it against that palate, along with, the mucus and saliva that's being secreted by the various salivary glands. Is going to help form this bolus. Then it's going to push, and it pushes it posteriorly. So here we go, going towards the back. Now the food is going to accumulate in the oropharynx, and when the bolus reaches to a critical size, the epiglottis, which you have here, the epiglottis is going to tip posteriorly, and the food bolus will slide around it through a space on each side of the glottis. So you notice here in this first diagram, we notice that the epiglottis is up. Here's our epiglottis. This is our oral, this is our oral pharynx. The oral cavity as well as the pharynx combined. So here's our oral pharynx that I'm referring to. Here is our laryngeal pharynx. Okay, and this is our nasal pharynx. This is area. All is just the pharynx, just divided up in 3 sections. Now, when the bolus is pushed backwards, you notice that the epiglottis is actually up. Now, when it reaches into this particular area, the oropharynx as well as the laryngeal pharynx area is going to flap downward so the food can get by. That's why a lot of our parents would tell us, hey, don't eat and drink at the same time, or sorry, not eat and drink. don't eat and talk at the same time, because here is your trachea dealing with the wind or the air getting into your lungs, and here is our esophagus, where the food is supposed to pass. So when you're eating and talking at the same time, the epiglottis will not function to its full capacity, allowing little bits of food to get into the trachea. Into the trachea, causing you to cough. Okay, so this epiglottis has to flap down, as you see right here, allowing the bolus to get by and to continue its way down into the esophagus. Alright, so now we're in this phase 2, our pharyngeal phase. Now this is an involuntary type of movement that will occur in here, and it has 3 actions that will prevent food and drink from re-entering the mouth or entering into the nasal cavity. So we have the root of the tongue is going to block. Here we have the root of the tongue. The root of the tongue is going to block the oral cavity. And then we have the soft palate, which will actually raise. There you go. The soft palate is going to raise and is going to block the nasal pharynx. And then we have the infrahyoid muscles are going to pull the larynx up to meet the epiglottis. Okay, while the vestibular folds are going to like adduct, meaning add means coming together, going to adduct to close the airway off. So we have a number of things that are occurring in this phase 2. Now the food bolus is going to be driven downward by the constrictions of the upper, then the middle, and then finally the lower pharyngeal constrictors. Now, as the bolus enters into the esophagus, it stretches and it triggers peristalsis. What's peristalsis? Peristalsis is basically that wave-like movement in helping the food or any substance move throughout the system. Okay. Now, the esophageal motility is entirely involuntary, although the upper muscle is skeletal. Now, this last phase here, the esophageal phase, is moderated by a short reflex through the myenteric nerve plexus. Now the bolus, it stimulates these stretch receptors, which is what it needs in the esophagus, correct? Which is going to send signals to the muscularis anterior, behind and ahead of, this is behind and ahead of the bolus, causing it to stretch. Okay. Now the circular muscle behind the bolus is going to constrict, which you see right here. Get this mouse working. Is going to constrict, and it pushes it downward, which is what we need. Now ahead of the bolus here, the muscles are going to relax, while the other longitudinal muscles are going to constrict. And it's going to pull the wall of the esophagus upward, making it wider. Now most food is going to pass by gravity when we are standing or sitting upright, but peristalsis ensures that food can be swallowed regardless of the body position. So we have 3 phases of swallowing. What are they? The oral phase, the pharyngeal phase, and the esophageal phase. So if you have printed off the PowerPoint, you would have been able to follow with me with the various phases. So I'm going to move on to the stomach. So now we have the food bolus in the stomach. And what's the stomach? Basically, it's a muscular sac. Let's see right here. And it's located in the upper left abdominal cavity. And it receives food, it stores it, breaks it down, and begins digestion to produce chyme. So what are the few functions I mentioned? It receives food, that's 1. It stores it, that's 2. It breaks it up, that's 3. And begins digestion to produce chyme. Now, in terms of gross anatomy, well, let's talk about chyme first. What is chyme? Chyme is basically dealing with the food that has been semi-digested. It has reached the stomach and is going to mix with a number of the acids and the substances that are being excreted within the stomach. So the definition in your book says it's the soupy or pasty mixture of semi-digested food in the stomach. So here within the stomach, we have the beginning of the digestion of proteins within the body. Proteins and fats. And carbohydrates start to digest in the oral cavity, and they continue to be digested all the way through. But just proteins and fats are they begin to digest within the stomach. So please remember that. Now, most digestion occurs after the chyme passes on to the small intestine. Now, when we look at the gross anatomy of the stomach, we see that it's shaped like a J, and is usually vertical in tall people and a little more horizontal in short people. Now, it has 4 major regions. We have a cardiac region, a fondic region. Here's our cardia. In the diagram it says cardia, but it has a cardiac region, our fondic region, our body, and our pyloric or pylorus. Now, within these regions, this is the small area within about 3 centimeters of the cardiac orifice, hence the name. Alright, we had the fundus region, little dome-shaped portion superior to the esophageal attachment. And we have the body, which is the largest, the greatest part of the stomach, which is distal to the cardiac orifice. And we have our pyloric region, which is slightly narrower pouch at the inferior end that is subdivided into the antrum and the pyloric canal. Now, at either end, we do have sphincters, which I don't have in this particular diagram. But at the beginning of the stomach, we have a cardiac sphincter, which helps control the amount of food entering into the stomach. And at the distal end, or at the end of the stomach, before it enters into the duodenum, which is the part of the small intestine, we have a pyloric sphincter, and those sphincters are there to control the amount of food entering and leaving various structures of the body. For example, we're dealing with the stomach, okay? Alright, so the stomach has a greater and a lesser curvatures. So in this diagram here to your right, you'll see that you'll have a lesser curvature, and then we have our greater curvature. Now, the lesser curvature of the stomach, it extends about 10 centimeters from the esophagus to the duodenum, and it's along the medial to superior aspect of the stomach. Now, the greater curvature, that extends, it has a longer extension. It's about 40 centimeters from the esophagus all the way to the duodenum. Okay. Okay, so here's another picture of the stomach. In your textbook, it's figure 22, 25, 12A, and you see the lesser curvature. You'll have the greater curvature, and you also see the fondic region, how it bulges out. We have our cardiac region. We have our body, and you see how the pyloric region starts to narrow out. Now, I mentioned earlier that it's divided into two sections, correct? Hope you guys remember what those two sections are. Okay. Now, we are looking at the greater omentum, and that greater omentum is basically going to hang down underneath the greater curvature. And you notice that it contains some blood vessels in there as well. That's going to attach to the stomach, and we have our lesser omentum, and that connects the stomach to the liver. This lesser omentum. You see this nice. It looks like fatty cells, but it is considered to be an omentum which connects the stomach to the liver. Okay, so hope you guys remember the two regions. I gave you guys a minute or two while I was talking about something else. You guys remember the two regions of the pyloric region? It's the pyloric canal and the antrum. So here is, get this working, here's our antrum, and here's the pyloric canal. I notice that the pyloric region is a lot narrower, but its sphincter is a lot thicker than the other sphincter, the cardiac sphincter up above. Okay. And here's another diagram of the stomach, and these little folds or wrinkles, what they're longitudinal wrinkles, those are called rugae, and you only see it on an empty stomach. Okay. Alright, so let's look at how the stomach works overall. Yes, it does have secretion of various acid, help with digestion of the food. But where are these signals coming from? So that's what we're going to look at. We're going to look at the innervation and the circulation of the stomach and the food, and where does everything come from. So the stomach is going to receive parasympathetic nerve fibers from the vagus nerves and the sympathetic fibers from the celiac ganglia. Now, it's supplied with blood from the celiac trunk, and all blood drained from the stomach and intestines enters the hepatic portal circulation before returning to the heart. Okay, so we're going to look at the microscopic anatomy of the stomach. So if you want to follow along, you can with your notes for this slide, but I want to go to the diagram itself, which is on the next slide. And you can also look at it in your textbook, figure 25.13a, I believe. Okay, so well, this is going to show the stomach wall, and this wall has tissue layers, and it's going to be similar to the esophagus, with some slight deviation. Then the mucosa is covered with simple columnar glandular epithelium. So here is our mucosa, this entire layer here. Now the apical regions of its surface cells are filled with mucin, and it's going to swell with water and then become mucus upon secretion. Now the mucosa and the submucosa, they are flat and smooth when the stomach is full. but form longitudinal gastric rugae when it's empty. So remember I showed you a few slides back the stomach with the rugae. That's what it's going to look like when it is empty. We're talking about those ridges that we'll find within the mucosa and the submucosa. Now the laminae propriae is almost entirely occupied by the tubular glands, and the muscularis externa, which we have here, this area here, it has 3 layers rather than 2. It has let me get this working here. Here we go. It has an upper longitudinal layer. It has a middle longitudinal, a middle circular layer, and then it has an inner oblique layer. Oops, I was going the wrong way. Here's your outer longitudinal layer. Here's your our middle circular layer, and here is our internal oblique layer. And this makes up our muscularis externa. Alright, and then we have our serosa layer that covers the entire stomach. Alright, so when we look at the gastric mucosa, it has these pockets. These pockets are called, or these depressions are called gastric pits, and they're also lined with columnar epithelial cells or tissue. Here we go. Those are very deep depressions in here. Those are called gastric pits. Now 2 or 3 tubular glands, they're going to open into the bottom of each of these pits. Get this working. Here we go. Of these pits, and they're going to span the rest of the lamina propria all the way down. So this one, you see this is slightly cut, so you really can't tell that it's coming from all the way up here, but the those glands or those pits are going to extend all the way down into the lamina propria region. So we have the gastric pits. The gastric pits contain these gastric glands at the distal end of them, and they extend all the way down into the propria, into the lamina propria. You see it better in this area over here. Okay, so these are the entire pits, and at the distal end is our gastric gland. Okay. Now, in the rest of the stomach, they're called gastric glands. Now, in the cardiac and the pyloric regions, they are called cardiac glands and pyloric glands, respectively. Okay, so here are the pits that I was referring to. You guys should see it a little better over here, which is nice. I like this diagram that I provided for you. We see the deep pits in there, and we said that they're different within each region. The glands that you find at the distal end of the pits, you have the cardiac gland, the pyloric gland, and the gastric gland. And all depends on what region they are located in. Okay. Alright, so let's look at the microscopic view of the stomach. We has 3 types of glands in different composition, but they contain the following 5 types of cells. We have the mucus cells. 1, 2, 3, 4. 4 of them are here on this diagram. We have the mucus cells, and those are the ones that are going to secrete mucus and predominate in the cardiac and the pyloric glands. Now, the gastric glands, they are called mucous neck glands, and that's because they are located in the neck of the gland, as you see right in this particular region. Now the regenerative or the stem cells, they're found in the base of the pit and the neck of the gland, and they divide rapidly and produce a continual supply of new cells. Now the parietal cells, which we see here, these parietal cells are found mostly in the upper half of the gland, and they secrete hydrochloric acid, which is an intrinsic factor, and of course ghrelin, which deals with hunger. It's a hormone that deals with hunger. And they are mostly found in gastric glands, but few can be found in the pyloric glands. Then we have our chief cells. Our chief cells, which are the most numerous and found in the lower half of the gastric glands. They secrete gastric lipase and pepsinogen. And then our last cell, called the enteroendocrine cells, they secrete hormones and apocrine messengers and are found mostly in the gastric and pyloric glands. They are at least 8 kinds of enteroendocrine cells, each of which produce a different messenger. So here we have, you see the difference between the pyloric and the gastric gland. No chief cells. All the pyloric gland has will have the G cell, the mucus cells, and the parietal cell. The gastric cell has both the G cells and the parietal cells, same with the pyloric, but it contains a chief cell as well as the mucus neck cell. Okay. All right, so let's look at the gastric secretions of the gastric glands. They're going to produce about 2 to 3 liters of gastric juice per day, composed mainly of water, hydrochloric acid, and pepsin. Now, gastric juice has a high concentration of hydrochloric acid and a pH of as low as 0.8. Now, the parietal cells, which we talked about just a few slides back, they contain a carbonic anhydrase, the CAH, which is going to catalyze the first step in this particular reaction. You can tell what catalyzes meaning breaking down. Okay, so the hydrogen is going to be pumped into the lumen of the gastric cell by an active transport of protein called HK-ATPase, which is an antiport. Right, so when we look at the hydrochloric, the HCl, when it's secreted, it does not affect the pH at all within the parietal cell. Now, the bicarbonate acid, the bicarbonate ions, which is what we have here, the HCO3, they're exchanged for chlorine ions from the blood plasma, and the same chloride shift that occurs in the renal tubules and the red blood cells, and the chloride is pumped into the lumen as well. So the blood leaving the stomach has a higher pH when digestion is occurring than when the stomach is empty. Alright, so the stomach acid has several functions. So what's it going to do? It activates the enzymes pepsin and lingual lipase. That's one function. Second function is going to break up the connective tissues and plant cell walls. 3 is going to convert digested ferric ions, which is right here, Fe3, to ferrous ions, Fe2, which can be absorbed and reused. And the other function, it contributes to non-specific disease resistance by destroying ingested pathogens. When we look at pepsin, pepsin is one of the digestive enzymes secreted as an inactive protein called zymogen, now which is then converted to an active form by removal of certain amino acids. Now in the stomach, chief cells, they secrete the pepsinogen, and the hydrochloric acid removes some of the amino acids to convert it to the pepsin. Now because pepsin digests protein and pepsinogen is a protein, so it's because pepsin digests protein and the pepsinogen is a protein, pepsin has an autocatalytic effect. As some pepsin is formed, it converts pepsinogen to pepsin. Now the ultimate function of pepsin is to digest dietary proteins to smaller chains that are then completely digested in the small intestines. So let's look at the gastric lipase. It's from the chief cells, which we mentioned earlier, and along with the lingual lipase, they digest approximately 10% to 15% of the dietary fibers. Now the intrinsic factor, a glycoprotein secreted by the parietal cells, is essential to the absorption of vitamin B12 in the small intestines. Now without vitamin B12, the hemoglobin cannot be synthesized, and the pernicious anemia develops. Now the secretion of the intrinsic factor is the only indisabling factor or function of the stomach. So as people get older, the gastric mucosa atrophies and the risk of perniosis pneumonia starts to increase. Now, as many as 20 chemical messengers are produced by the gastric and the pyloric glands, enteroendocrine cells. Now, most are hormones that travel in the blood to distinct target cells. And some also behave as paracrine secretions. Several are peptins produced in both the digestive tract and the CNS, the central nervous system, and are thus called gut-brain peptides. Now these include substance P, vasoactive intestinal peptide, the VIP, secretin, GIP, the gastric inhibitory pepsin, the NPY, and the stokinin, which is this one right here. Alright, so we deal with swallowing. Let's deal with the gastric motility. This is what's going to help with the digestion, or in turn ingested food into chyme. Now, upon swallowing, the swallowing center of the medulla oblongata, it signals the stomach to relax. Now, the arrival of the food is going to stretch the stomach, and then it's going to activate these receptive relaxation responses by which the stomach relaxes to accept more food. Now, the stomach soon shows rhythmic peristaltic contractions about every 20 seconds that are governed by these pacemaker cells in that longitudinal layer of the the muscularis externa of the greater curvature. Remember we talked about the muscularis externa. It has 3 layers. Hope you guys remember those 3 layers. Now after 30 minutes, these contractions become quite strong. Now the antrum, which remember is part of the pyloric region, it holds about 20 milliliters of chyme. Now as the peristaltic waves they start to pass down, the antrum, they squirt out about 3 milliliters of chyme into the duodenum. So that's why we have that sphincter there, to make sure it controls the amount of chyme being passed into the duodenum, which is part of that small intestines. Okay. Now when the waves reach this pyloric sphincter, it squeezes the sphincter shut, and then the chyme that does not get through, it turns back into the antrum. So those that don't get passed through, it stays back into that antrum area until that sphincter reopens and it's squirted right out into the duodenum. Now receiving only small amounts of the chyme at a time, it allows the duodenum to neutralize the stomach acid and digest the nutrients a little bit at a time. Now a typical meal is emptied from the stomach in about 4 hours. Now vomiting. Let's see vomiting. Oh yeah, they already do vomiting. Now of course with less time, if you consume a lot of liquids while you're eating, so I say don't eat and drink at the same time, because it takes there's a longer time for the food to digest, because it has to try and deal with the fluid that you just put in there and try and get to the food to the food particles or the chyme to break it down. You know, as long as 9 hours for a high fat meal. It takes very long for those meals. And of course high protein as well. Alright, so let's deal with vomiting. What is vomiting? Vomiting is basically called forceful ejection of stomach and intestinal contents, also called chyme, from the stomach. It occurs when the abdominal contractions and raising of the thoracic pressure is going to push, it forces the upper esophageal sphincter open and the esophagus and the body of stomach to relax. And of course the chyme is then driven out of the stomach and mouth by a strong abdominal contraction along with reverse peristalsis. Alright, so remember we talked about the esophagus here, and then we have our stomach. Alright, and this is the upper esophageal area that we're referring to, okay? And then we have the lower esophageal sphincter. It's also called the cardiac sphincter. You've heard me say cardiac sphincter, hope you're not confused. Cardiac sphincter and lower esophageal sphincter, basically the same thing. In some books you see cardiac sphincter because you have the cardiac section or cardiac region of the stomach. Okay. Alright, so what causes vomiting? Overstretching of the stomach and the duodenum. We have chemical irritation such as alcohol and bacterial toxins, visceral trauma, or we have intense pain and psychological and sensory stimuli. Alright, so now projectile vomiting is sudden vomiting with no prior nausea or retching. Now when we look at retching here, we're dealing with thoracic extension and abdominal contraction, which creates a pressure difference that dilates the esophagus. Now the lower sphincter is going to relax when the stomach and the duodenum contract spasmodically. Now the chyme is going to enter into the esophagus, but then it's going to drop back into the stomach as the stomach relaxes. It doesn't get pushed. It doesn't get past the upper esophageal sphincter at all, and usually it's usually accompanied by tachycardia, which is an increased heart rate, profuse salivation, and of course with sweating. Now we do have okay, I kind of jumped ahead of myself, but here we have talking about vomiting and projectile vomiting. Of course, projectile vomiting is common in infants when they are feeding. So they won't have the nausea, but they'll just start vomiting. Okay. Alright, then we have chronic vomiting. Chronic vomiting can cause dangerous fluids, electrolyte, and acid-base imbalances. Now, in cases of frequent vomiting, as in the eating disorder bulimia, it can cause tooth enamel. The tooth enamel becomes severely corroded by acid in the chyme. So a lot of times, I know I was always told to, whenever you vomit, make sure you brush your teeth right after you vomit, just to make sure you don't have an accumulation of acid on your teeth. So it doesn't even have to be chronic. You don't even have to suffer from chronic vomiting, but any type of vomiting, just make sure that you brush your teeth afterwards. Okay. Alright, so aspiration of acid chyme or inhalation of acid is very destructive of the respiratory tract. Okay, and many have died from aspiration of vomit when unconscious, of course, or if the person is semi-conscious. So that's basically if someone is vomiting in their sleep, or semi-conscious. Then we have surgical anesthesia must be preceded by fasting until the stomach and the small intestines are empty. Alright, so digestion and absorption. Now the salivary and the gastric enzymes partially digest protein and lesser amounts of starch and fat in the stomach. Now most digestion and nearly all absorption occur after the chyme has passed into the stomach. Now the stomach doesn't absorb any significant amount of nutrients, but it does absorb aspirin and some lipid-soluble drugs. Now alcohol is absorbed mainly by the small intestine, as is intoxicating effects depend partially on how rapidly the stomach is emptied. Now, protection of the stomach from self-digestion is accomplished by three means. What are they? They are mucus coat. We have tight junctions, which I did not highlight. Let me highlight that now. So we have our tight junctions as well as the epithelial cell replacement. So when we look at the mucus coat, that mucus coat is very thick, highly alkaline mucus that coats the stomach. Resist the action of acids and enzymes. Now the tight junctions, those are between the epithelial cells, and they prevent the gastric juice from seeping between them and the digesting deeper tissue. The epithelial cell replacement. Now the stomach's epithelial cells, they live only 3 to 6 days and are then sloughed off, meaning that they're like shedded off or slightly moved off. Now they are rapidly replaced by cell division in those gastric pits. Now breakdown of the protective measures can result in inflammation and peptic ulcers. So here we have a peptic ulcer. Gastritis, which is inflammation of the stomach. Itis meaning inflammation. Gast with the R is basically dealing with the stomach, and it can lead to peptic ulcers as the pepsid and the hydrochloric acid start to erode on the stomach. So here we have it right here. Now most ulcers are caused by acid resistant bacteria, the Helicobacter pylori, and they can be treated with any type of antibiotics. Alright, so the nervous system, as we know, it regulates everything in the body. The endocrine system, it plays a major role in how things are dealt with within the body. Now the gastric activity is divided into 3 stages, and they're called the cephalic, gastric, and intestinal phases, and they're going to overlap and may even occur simultaneously. So let's look at the cephalic phase. Here's our cephalic phase. Now this is the phase in which the stomach is going to respond to just mere sight, smell, touch, or even thought of food. So if you're hungry right now, you're dealing with the vagus nerve. We're dealing with the cephalic phase. Now these sensory and the mental inputs, they're going to convey that information to the hypothalamus, which is up in here, which is in that brain, in this area of the brain, which is going to relay the information to the medulla oblongata. Now the vagus nerve, the nerve fibers from the medulla oblongata, they're going to stimulate the enteric nerve system of the stomach. So we're dealing with input, sensory input. We're dealing with smell, taste, touch, and thought. The information is conveyed to the hypothalamus, which then relays that information to the medulla oblongata. Then vagus nerve is going to stimulate the enteric nervous system of the stomach, where we'll have gastric secretions even before we start swallowing. So even when we're chewing gum and the stomach's not receiving any food, we're going to have gastric juices being secreted, ready to enter the food. It's like some people say it's not good to chew gum, because you're stimulating the stomach to receive food, and it's secreting all these gastric juices or fluids, and nothing's there. Alright, so let's get on to the gastric phase. The gastric phase is a period in which swallowed food and semi-digested protein activate the gastric activity. So we have approximately 2/3 of the gastric secretions occurs during this phase. We have the ingested food. It's going to stimulate the gastric activities in 2 ways. 1, by stretching the stomach. 2, by raising the pH of its contents. Now the gastric secretions is stimulated briefly by 3 chemicals. We have let me see if I can write these down for you guys. Pen. And okay. Pen. Pen. Alright, let's do this pen. Alright. And 3, let's see, what was I talking about now? Oh, it's the three chemicals. The three chemicals. So the gastric secretion is stimulated briefly by three chemicals. What are they? They are the A the ACH, which is our acetylcholine. We have our histamine, which I'll just highlight here, our histamine, and our gastrin. Those are the three chemicals that are stimulated, that are chiefly stimulated by the gastric secretions. Now, the acetylcholine is secreted by the parasympathetic. I'll just write here. By the parasympathetic. Don't mind my writing, guys. Then we have the histamine is hold on, let's go back to the acetylcholine. The acetylcholine secreted by the parasympathetic nerve system. Fibers are of both small, short, and long reflex pathways. Our histamine is a paracrine. So I'm not used to this mouse. By a paracrine secretion from the enteroendocrine cells of the gastric glands. And then we have the gastrin, which is a hormone produced by the enteroendocrine G cells in the pyloric gland. I'm not even going to try and write that stuff because it's messing up my paper. Okay, so let me see if I can erase this somewhere. Nope. There we go. Okay. Alright, so let's continue. We talked about the three chemicals, the acetylcholine, the histamine, and the gastrin. That's going to be chiefly stimulated by the gastric secretion. Okay, we're still in this phase here. Now, all three are they're going to stimulate the parietal cells to secrete hydrochloric acid and the intrinsic factor. Now, as dietary protein is digested, so as we eat the protein, it's broken down into smaller peptides and amino acids, which are going to directly stimulate those G cells to secrete more gastrin, giving us a positive feedback loop. Now, as digestion continues, the peptids are emptied from the stomach, and the pH drops. Now, anything below a pH of 2, the parietal cells and the G cells are inhibited. So it means they're going to stop their action. And that's going to cause a negative feedback loop. So because something is being stopped. When dealing with a positive feedback loop, you have the continuation of something. You need it stimulated. Oh, we need more. All right, let's secrete some more. Let's secrete some more. Secrete some more. When you do a negative feedback, instead of something's just been secreted, let's stop the secretion of, let's say, of A, while B is being utilized. Okay. Now, our third one is our intestinal phase, and this is the stage in which the duodenum responds to arriving chyme, and it starts to modify or moderates the gastric activity through hormones and nervous reflexes. Now, duodenum, it initially enhances the gastric secretion, but soon inhibits it. It stretches. We have stretching of the duodenum, which is going to activate the vagal reflexes that stimulate the stomach. And we have amino acids in the chyme that are going to stimulate the G cells of the duodenum to secrete more gastrin, which further stimulates the stomach. So this increase of acid and semi-digestive fats in the duodenum, they trigger the enterogastric reflex, by which the inhibitory signals are sent to the stomach by way of the enteric nervous system. Now the signals are sent back to the medulla oblongata that accumulates two actions. The vagal nuclei is inhibited, reducing the vagal stimulation of the stomach, and then we have the sympathetic neurons are stimulated. Those are stimulated, sending inhibitory signals to the stomach as well. So here's our vagal nerve nuclei. They're going to inhibit, reducing the vagal stimuli, and then we have the sympathetic neurons. They're stimulated, sending inhibitory signals to the stomach, basically telling it to stop. Alright, so chyme also stimulates duodenal enteroendocrine cells to release secretin and CCH, which stimulates the pancreas and the gallbladder, but also suppresses the gastric secretions and the motility. So this chyme stimulates the CCH, CCK, and the secretin, or the secretin. And while those are being secreted, it's going to stimulate the pancreas and the gallbladder, stopping the gastric secretion and the motility of the chyme. Now the enteroendocrine cells also secrete glucose-dependent insulin, the GIP, insulinotropic peptide. Now this peptide now appears to be more concerned with stimulating insulin secretion. So I have all the phases here for you. I just left it on that diagram because I wanted you guys to see exactly what is going on within those particular phases. So I'm going to skip all the way through to the end. If you have any questions, I know this is a lot of terms that we're dealing with here. Please send me an email. Not email, I'm sorry. Go on Blackboard and ask any questions. It is a little bit confusing. I'll see if I can get a review sheet ready for you guys. Alright, make sure you guys look at part 3 of our part 4 series of chapter 26.